Hypothyroidism is a condition that's caused by having insufficient thyroid hormones. Thyroid hormone production is under the control of the hypothalamus and the pituitary. The hypothalamus secretes thyrotropin-releasing hormone, or TRH, and TRH stimulates the anterior pituitary to secrete thyroid-stimulating hormone, or TSH. TSH then binds to TSH receptors, which makes the thyroid secrete thyroxine, or T4, and triiodothyronine, or T3, in the blood. But this isn't a one-way street. There's also negative feedback happening, meaning when thyroid hormone levels rise, that inhibits the production of TSH and TRH, halting further production of T3 and T4 to keep everything in balance. Normally, some thyroid hormones travel through the bloodstream bound to thyroid-binding globulin, and some are in their free form. The thyroid actually makes more T4 than T3, and that T4 is converted into the more potent T3 in the periphery. Thyroid hormones then increase the rate of metabolism in all cells, so they make us think, move, and talk faster, and they also increase heat generation. They activate the sympathetic nervous system, the part of the nervous system responsible for our fight or flight response, increasing cardiac output. So with hypothyroidism, it's like the entire body is functioning in slow motion. But this happens gradually, so it can take years before symptoms are even recognized. These include weight gain, despite a loss in appetite because of the lower basal metabolic rate, cold sensitivity because the body is producing less heat, and slower heart rate, mental slowness, lethargy, and constipation because of the decreased effect of thyroid hormones on the sympathetic nervous system. With hypothyroidism, glycosaminoglycans can also accumulate in the skin and soft tissues, causing myxedema, or swelling, and an enlarged swollen tongue. Individuals may also have a puffy face, like a person who's just woken up, coarse hair, periorbital edema, as well as loss of hair in the lateral third of the eyebrow, which is called Queen Anne's sign. There might also be muscle aches and a delayed relaxation phase of the deep tendon reflexes. Hypothyroidism also causes menstrual irregularities in females and erectile dysfunction in males. These signs and symptoms should prompt obtaining serum levels of free T4 and TSH to confirm the diagnosis. Now, hypothyroidism actually comes in two flavors: primary, meaning it's a result of a thyroid condition, and secondary, or central, in which case the problem is a decreased secretion of TSH or TRH. Primary hypothyroidism is much more common, accounting for over 95% of cases, and blood tests show low levels of free T3 and T4, which signals the pituitary to produce more TSH, so a high TSH. In high-income countries, the most common cause of primary hypothyroidism is Hashimoto's thyroiditis. Hashimoto's is an autoimmune form of thyroiditis, where autoantibodies are directed against the thyroid gland, and, as a consequence, more and more thyroid tissue gets destroyed over time, resulting in chronic hypothyroidism. And when there's an immune attack, there's inflammation. This inflammation makes the thyroid gland enlarge, so that can result in a goiter on physical examination. Finally, blood work may show high levels of anti-thyroperoxidase, or anti-TPO antibodies in the serum. Treatment for Hashimoto's thyroiditis depends on whether or not hypothyroidism is present. In euthyroid patients, no treatment is required. In patients with chronic hypothyroidism, however, treatment is lifelong substitution therapy with T4. There are other kinds of thyroiditis that can also cause hypothyroidism, particularly subacute thyroiditis, also called de Quervain's thyroiditis, which is associated with an inflamed, painful thyroid gland and flu-like symptoms like high fevers and muscle aches. It can occur after a viral infection and develops in 3 phases. At first, the follicles get destroyed, so T3 and T4 spill out into the blood, creating a transient hyperthyroid state, with low TSH levels. In some cases, after 6 to 8 weeks, the inflammation subsides on its own, and the thyroid follicles repair themselves, so thyroid function goes back to normal without any treatment. But sometimes, after the initial hyperthyroid phase, individuals become slightly hypothyroid, before eventually returning to normal thyroid function. The inflammation causes a high erythrocyte sedimentation rate, or ESR, typically in the range of 60 to 100. Another type of thyroiditis is postpartum thyroiditis, which affects some females 2 to 12 months after giving birth. One explanation is that the immune system is generally diminished during pregnancy, so that there's no attack against the fetus. And then, after childbirth, the immune system becomes more active again, and at that time it might mistakenly attack the thyroid gland. Like subacute thyroiditis, there's a hyperthyroid phase, followed by a hypothyroid phase, which occurs around 5 to 7 months after childbirth. And finally, there's a return to normal thyroid function. Both subacute thyroiditis and postpartum thyroiditis often cause minimal symptoms and resolve on their own over 12 to 18 months. In those situations, only pain management is needed, and sometimes beta blockers may be helpful during the hyperthyroid phase. During the hypothyroid phase, asymptomatic individuals require no treatment, whereas those who develop symptoms should be treated with T4 for several months. Once they have a normal serum TSH level, confirming the recovery of their thyroid function, exogenous T4 can be stopped. Occasionally, however, these diseases progress to permanent hypothyroidism, in which case lifelong substitution therapy with T4 is necessary. Okay, now let's switch gears and look at iatrogenic causes of primary hypothyroidism. First off, hypothyroidism can occur following surgery or radioiodine treatment for hyperthyroidism, either because the surgery removes part or all of the thyroid gland, or because radioiodine therapy damages too many follicular cells. For example, hypothyroidism usually begins with 2 to 4 weeks after a total thyroidectomy, which is when the entire gland is surgically removed. By comparison, hypothyroidism usually begins up to a year after a subtotal thyroidectomy, which is when most, but not all, of the gland is removed. With radioiodine treatment, a person swallows a capsule containing a small dose of iodine-131, which emits radiation. Functional thyroid tissue loves iodine and gobbles it up to make thyroid hormones, and the iodine destroys the follicles with radiation, like a Trojan horse. Hypothyroidism can occur months to years following radioiodine treatment, and it's based on the extent of the follicular damage. Another cause is when individuals get neck radiation to treat a cancer in the neck region, and the thyroid becomes a collateral victim. Hypothyroidism can also result from side effects of other medications, including antithyroid medicine like methimazole and propylthiouracil, which are used to treat hypothyroidism due to Graves' disease. Other medications include lithium, which treats bipolar disorder, amiodarone, an antiarrhythmic, interferon alpha, as well as anti-cancer medications like tyrosine kinase inhibitors, an example being sunitinib, and checkpoint inhibitors like nivolumab, pembrolizumab, and ipilimumab. In individuals taking these medications, serum TSH should be checked every 6 to 12 months to screen for hypothyroidism, and if it develops, T4 therapy is started right away. In low-income countries where salt and drinking water are not fortified with iodine, the most common cause of primary hypothyroidism is iodine deficiency. In these settings, individuals aren't able to make thyroid hormone, and the constant stimulation from TSH results in hypertrophy of the thyroid gland, a goiter. Treatment relies on lifelong substitution therapy with T4, and sometimes a thyroidectomy is done if individuals have really large goiters that are compressing nearby structures, like the trachea causing trouble breathing, or the recurrent laryngeal nerve causing hoarseness. Interestingly enough, iodine excess can also cause hypothyroidism. Some background here. Normally, the first step in thyroid hormone synthesis is iodine organification. That's where iodide is incorporated into monoiodotyrosine, or MIT, and diiodotyrosine, or DIT, which are later used for thyroid hormone synthesis. Initially, iodine excess leads to more thyroid hormone synthesis. But over time, there's an inhibition of iodide organification, and it's called the Wolff-Chaikoff effect. That helps to keep the thyroid hormone levels from creeping too high. Over time, the thyroid gland adapts to excess iodide by taking less iodide into the follicular cells, And so, the Wolff-Chaikoff effect, the inhibition of iodide organification, goes away over time. This is sometimes called escape from the Wolff-Chaikoff effect, which may sound like an episode of Star Trek, but it's not. Now, in individuals with underlying thyroid pathology, like Hashimoto's thyroiditis, the Wolff-Chaikoff effect is more pronounced, and there's no escape. So, there's persistent inhibition of thyroid hormone synthesis, which leads to a goiter and hypothyroidism. Luckily, the disease regresses upon withdrawal of excess iodine. But when there are severe symptoms, substitution therapy with T4 can be used until thyroid function recovers. Finally, if primary hypothyroidism occurs in a newborn, it's called congenital hypothyroidism. The newborn's thyroid gland doesn't make enough thyroid hormones, either because it doesn't develop normally, the gland can be absent, underdeveloped, or develop in the wrong place in the body, or because there's a functional defect that makes the gland unable to make thyroid hormones. Congenital hypothyroidism may cause severe defects in neurological development and growth, so screening by obtaining a serum TSH and free T4 is recommended in all newborns, and it's usually done when the baby is a few days old. If hypothyroidism is detected, treatment with T4 is initiated immediately, with the goal of normalizing thyroid hormone and TSH levels by 3 weeks of age. Now, in secondary or central hypothyroidism, there's a decreased secretion of TSH and TRH, so blood tests show low free T3 and T4 and a low TSH. The most common cause of central hypothyroidism is a pituitary tumor, but it can occur with head trauma, Sheehan syndrome, which is where there's postpartum pituitary necrosis, hypophysitis, which is inflammation of the pituitary, and non-pituitary tumors, like craniopharyngiomas, which compress the pituitary from the outside. Since all of these affect the pituitary, the TSH deficiency may be isolated, or there may be other hormone deficiencies as well. For example, there may be a reduction in growth hormone-releasing hormone, or adrenocorticotropic hormone, or ACTH. Similar to TSH, TRH deficiency can also be caused by things like tumors and head trauma. Individuals with a pituitary or hypothalamic lesion should get an MRI of the head. If a tumor is identified, then it may be surgically removed, and treatment usually relies on T4 substitution therapy to replace a deficient thyroid hormone. However, before starting T4 substitution therapy, it's important to assess for other hormone deficiencies. For example, pituitary production of ACTH may also be decreased, leading to secondary adrenal insufficiency, or low adrenal production of cortisol. To keep cortisol levels normal, hepatic degradation of cortisol also slows down. Giving T4 to these individuals speeds up hepatic degradation of cortisol, making cortisol levels plummet and precipitating an adrenal crisis. So if there is adrenal insufficiency, then glucocorticoids should also be given along with T4 therapy. Finally, there's a life-threatening extreme of hypothyroidism called myxedema coma, which can occur in both primary and secondary hypothyroidism of any cause. Myxedema coma often occurs in older individuals, most commonly triggered by winter months, infections, or trauma. You can think of an old lady with the flu that goes out in the winter snow and slips on ice and breaks her hip. These situations cause stress, and the body normally responds by increasing thyroid hormone production to speed up metabolism in order to respond appropriately. However, in hypothyroid individuals, this is not possible, so these circumstances can precipitate myxedema coma. Symptoms include a low body temperature, bradycardia, severe hypotension, and ultimately can lead to coma. Individuals may also present with respiratory failure, in which case intubation and mechanical ventilation may be necessary. In myxedema coma, there's a low free T4 and high TSH in the case of primary hypothyroidism, or both low free T4 and low TSH with central hypothyroidism. Also, a complete blood count and cultures should be obtained to look for an infection, and an arterial blood gases and a basal metabolic panel should be obtained to assess for acid-base and electrolyte imbalances. The treatment is intravenous T3 and T4 to normalize thyroid hormone levels, glucocorticoids until adrenal insufficiency is excluded, and supportive measures like using warming blankets to bring body temperature back up. Individuals should also be started on broad-spectrum antibiotics until cultures exclude an infection. Alright, as a quick recap. In high-income settings, the most common cause of primary hypothyroidism in iodine-sufficient areas is Hashimoto's thyroiditis, which can be confirmed by the presence of anti-TPO antibodies in the serum and requires lifelong T4 therapy. Subacute thyroiditis and postpartum thyroiditis can also cause hypothyroidism, but they resolve over time, and treatment with T4 is only required with severe symptoms. In low-income settings, the most common cause of primary hypothyroidism is iodine deficiency, which can be prevented by fortifying table salt and drinking water with iodide. All newborns should be screened for congenital hypothyroidism and treated with T4 so as to normalize thyroid hormone levels by 3 weeks of age. Secondary hypothyroidism typically results from a pituitary or hypothalamic lesion, and it's sometimes associated with other hormone deficiencies like ACTH. Thyroid hormone substitution therapy must be initiated, and in the particular case of concomitant adrenal insufficiency, glucocorticoids should be given as well. Finally, myxedema coma is a life-threatening complication of hypothyroidism that requires immediate treatment with intravenous thyroid hormones.